So, hello, hello everybody to tonight's session of the Virtual Global Spine Conference. I'm very happy that we have a special guest I know very well, Dr. Alex Spiessberger. He is working in the Cleveland Clinic and he's a spine surgeon and he has got the same name like me. And I'm really excited to host him because he will present some challenging cases. The solutions sometimes appear like a Gordian knot. And I really like to hand over to Dr. Spiessberger. And I'm so glad that you joined us here. I know you've been working in Switzerland as well, and you know the hospitals I'm working with here very well. And maybe we have some insights in common, maybe something is completely different. And I'm really excited and thank you very much that you took the time and present your cases.
Well, thanks, Alex, for the introduction and the invitation. I do have to admit it was a sort of a last-minute invitation. Some of the slides might be a bit rudimentary, but I'm really looking forward to presenting some of the cases. I think it's going to be interesting because those cases are not only, they were challenging to me, but also they were, I think, pretty controversial. And I think probably many people might have different opinions of what should have been done. And I think really those cases really live off the discussion. So please feel free whenever you have any thoughts on what you would have done or any critical comments on my actions, please feel free to just pop in. My disclosures are really of no relevance. I only receive research funding from Novasiv and Stryker, which does not interfere with my talk. Okay, I prepared 4 cases, and I'm going to jump right to the first one. That's a 73-year-old male patient that presented to our clinic with really incapacitating back pain as well as bilateral leg pain. He has had previous surgeries, as you can see here in this X-ray. He had an L4-S1 fusion that was, if I remember right, 2015. He did do well for some time after that fusion, and really for the past 2 years, he's been steadily going down. Leg pain as well as back pain is equally bothersome to the patient. He did see that initial surgeon again, and that surgeon inserted a spinal cord stimulator. The stimulator really got him some relief at the beginning, but over the past 6 months, really nothing he tried helped. He has been on oxycodone, I think, Q8 hours, and just in miserable condition. He is unfortunately also a pretty sick guy. He has atrial fibrillation. He has some cardiac issues. He has I think a pacemaker. He has COPD, which is in him, I think, was only grade 1 hypertension. And overall, gentleman in pretty bad shape. That would be the whole spine standing X-ray. And what it essentially shows is that not only does he have a pretty substantial adjacent segment breakdown at 3-4, but also his lower spine, L4 to S1, is pretty deformed and pretty straight. I think the lordotic angle is down to only 5 degrees. He has a substantial pelvic tilt of 30-something degrees. Let me just quickly arrange my screen here. Yeah, pelvic tilt of 37 degrees, which can obviously tell you that he is substantially compensating for his deformity. His mismatch is up to around 30 degrees. So a substantial deformity plus substantial adjacent segment disease, which really explains well why he's doing so bad. Because of his pacemaker, he couldn't get an MRI, so we did a myelogram. They did inject him just above that fusion, as expected also already from the X-ray. There's high-grade spinal stenosis at L3-4. The 3-4 disc seems pretty mobile with quite a pronounced vacuum phenomenon. And the 4-to-1 fusion he had, that was done without any interbodies, that is solidly fused, and you see that the fusion mass here, the posterolateral fusion mass, extending down to the sacrum. So I guess he's old and he's quite some significant comorbidities, but you still need to offer something to him. So I guess the question now becomes on what to address. Would you only address the adjacent segments at 3-4? Should the whole alignment or the whole deformity be addressed? Should you maybe also pay attention to the alignment of the fused segment 4-1? And if you do surgery and if you do fusion, obviously, what are your fusion levels? So at this point, maybe I'm going to ask the audience or the faculty what the opinion is.
Oh yeah, this is a great case, Alex. So this is pretty common. And in my experience, L4S1 fusion was really frequent, like 10, 12 years ago. At that time, we treated also back pain without spinal stenosis, just back pain due to osteoarthritis of the facet joints. I myself did a lot of fusions like these and with happy patients for a couple of years, like 3 years or 5 years until ASD problem occurred. And I have seen several patients with adjacent level disease, and they went into a flat back. But this slip is really chilling. So I think conservative treatment, even with the SCS, and the patient is miserable. I think the decision to go for surgery is maybe easy for a surgeon, but the patient can be maybe is very disappointed by the history and will refuse. In the chat box, Dr. Birchuk, he is a follower since many months or years. He said maybe L3-4, treating L3-4 is enough. And I know there are deformity surgeons who would go really high, like T10 pelvis. Do you have any DEXA? Do you do all this work up, bone quality, densitometry?
So he did not have a DEXA scan. Basically, I know that's probably not the way it should be done, but I did just eyeball his bone density based on the Hounsfield units of his CT scan. So I don't know what his exact bone density is, but I think if I could just quickly respond to that comment, probably most of his disability is coming obviously from that L3-4 slip. But I think the question becomes, the question is, if you just treat that 3-4 without addressing the whole deformity, how long is it going to be until he fails above that? So even though he's 73 years, he was in pretty good shape until 2 years ago. So he still has a few years left, hopefully. So I think really the question becomes on whether you can, for how long you can get away ignoring that deformity.
Yeah. So it's really important to meet the expectations of the patient. So even if you go for a long deformity correction, you're not aware that there's no proximal failure. There's always another surgery in my mind. And I think I like, in this situation, I like to treat because the myelogram looks pretty nice above L3. I think maybe it's really a good, when the patient agrees and you have your extensive talk to just do L3-4.
Okay.
The posterolateral fusion mass is nice. Maybe you can connect to the existing construct. That means 2 new screws and the cage, decompression, wide decompression, and getting as much lordosis as you can get.
I think that's definitely a valuable suggestion. I think the question also becomes on how do you do your interbody fusion? Would you do just a a posterior or lateral. I think all that's probably different options you have. So I think from what I hear is you would just go one up with an interbody. I think that's probably not a bad suggestion. Now, any other thoughts or any other comments before I show what I did?
Yeah, is the SCS still working? Is the stimulator still working? Can
It
you
is
check it out?
Yeah, it is. It was working up until we did the surgery. So at that point, it was working, but it didn't really give a lot of relief, which is, in my experience, quite common. That if patients do have surgery with surgeons in a private practice, and they do something and then run into difficulties where more surgery would be required, then as a sort of a measure of out of desperation, they put a spinal cord stimulator, and that really usually does not do a lot for mechanical pain or pain related to deformity. So yeah, he still was in a lot of pain despite the stimulator working just fine.
And do you tend to let the stimulator in because it's a $25,000 device, and leaving it inside can mean you can save a lot of money?
So I during surgery I give my best to leave it in place, but I rarely recall that I ever managed to not dislodge the leads when I go back in. So yeah, it is a bit of an issue dancing around those leads.
Yeah. So Dr. Bavali from Florence in Italy said that he would try to do an XLIF to not get into trouble with the scars, with the fibrosis. So I think we were all excited to see your solution.
Okay, right. So what I did, I think, is a bit on the maximum side of the spectrum. After I got to know the patient and got to know what his expectations were, I did feel it was important to address the deformity as well. So what I did is basically I went in, I ended up doing an L2 to pelvis fusion. I basically went to get more lordosis. I disconnected the fusion mass at L5S1, did a 3-column osteotomy, not a full-blown pedicle subtraction osteotomy, just a corner osteotomy of S1, and then I T-lift L3-4. And the rationale behind this is that I do believe that not only does it matter to really achieve your alignment goals in terms of PI-LL mismatch, but also I think it matters on how and where exactly you recreate your lordosis. And obviously, the lower lumbar spine is where most of the lordosis is situated, so it makes sense to get your lordosis down there instead of doing an XLIF or an ACR at 3-4. And that's not only, I think that's not only a belief, but there is increasing literature on this subject that actually shows that recreating the spine in a physiologic way, meaning that most of the lordosis is recreated at L4 to S1, has pronounced positive effects on global alignment, also on compensatory mechanisms, and also potentially on the failure rate of our constructs. So I really think that's an appealing concept. Now, this is how the whole situation looked after surgery. It's doing any 3-column work down at the junction really has a pronounced effect on the global alignment. As you can see in this patient here, we were able to get almost 20 degrees of lordosis in his lower spine. His global lumbar lordosis, it almost overcorrected up to plus 30 degrees. And his pelvic tilt almost immediately dropped down to a normal value. And that's also something that the ISSG studies show, that recreating a physiologic alignment really takes out the necessity for compensatory mechanisms. Now, the X-ray I would say, looks okay. The downside is obviously that's a significant surgery took 7 hours. Blood loss was substantial. Patient spent 2 days in the ICU. He even was intubated for 24 hours. And another main issue, at least in my hands, is if you do 3-column work at the sacral dome, you cannot do, or you lose your ability to put in S1 screws. Now, what the real implication is mainly it's quite difficult to close the osteotomy side with only 1 distal screw. And I even did have a complication related to that maybe 2 months ago, where I had an extensive epidural hematoma after something like that, which I think was only caused by the inability to properly close the osteotomy. So I don't want to sweet talk this. It's a big surgery, and it has put quite some potential complications. And I think the future has to show if that concept of recreating a normal spinal alignment really outweighs the disadvantages or the risks of such a surgery.
Yeah, Alex, this is a really impressive correction. I think what you mentioned from the papers is that with every 5 years, there's a new parameter getting more and more important. So in the last year, I learned that the lumbar distribution index, the amount, the percentage of lordosis from L4 to S1 in comparison to the global lumbar lordosis to LL is so important. And I think you managed to make the lumbar distribution index better. But as you mentioned, at what price? You know, what can I ask you? How do you perform these osteotomy? What do you cut first? How do you proceed? Can you maybe in 30 seconds tell us step by step? Because I think a PSO is quite known, but S1 corner osteotomy is not in everybody's hands.
Yeah, well, it's to be honest with you, it's definitely, at least in my experience, probably the most challenging type of osteotomies. If you go into a revision setting and then at the lumbosacral junction, because at L5S1 you cannot really do, at least I don't feel so comfortable doing that lateral wall dissection. So I think key to me is at least really exposing the scar, and then really defining the bony borders. Try to see dura all around, left, right, inferior, and superior, and then trying to, before I do any bony work, really mobilize the thecal sac from any adhesions and scar tissue. And then basically, when I'm in, just trying to isolate or skeletonize the S1 pedicle, and then with the fluoroscopy, just basically aiming with the osteotome and taking out a wedge of S1. And then, I mean, that's not, I would say, once you have everything exposed, it's not so difficult. I think what's really difficult is getting that closed with only 1 distal screw, because usually with a 3-column osteotomy, the way I close this is really over contouring the rod and counter levering the rod in to nicely close it. And with only 1 distal screw, that's quite difficult. And yeah, as I said, I don't want to lie about this. It's quite difficult to do, at least in my hands.
Would you do something different if you can do it again? Would you choose like L5 PSO or? What I've been discussing, actually, I did the case with a fellow, and we've been discussing actually during the case already, if it would be easier next time, so to speak, after disconnecting the fusion mass, to flip the patient and do an ALIF. I think that's another way of doing it, even though I have to say that once everything is exposed and the fusion mass disconnected, from that point on, there was not so much more extra blood loss. So I think what really drove the blood loss up was the exposure and the disconnection of the fusion mass. Yeah, seeing the belly in prone position is not a big invitation for an ALIF as well.
In this patient, for sure, yeah.
Yeah. Oh, thank you. This was quite impressive, and I haven't done any S1 corneostomy since years. I've seen one 10 years ago. I think this is really a technique for the ones who are looking for a definitive correction deep down in the base of the spine. It is great to see this case. Thank you.
All right. So second case is, I would say, a little bit more of a bread and butter case. So this is a gentleman that I saw. He was a just retired, a police officer, 57 years old. He did have a 2-level ACDF done by another surgeon, and that was around 6 months before I met him. He did have, prior to this, his issue was really a cervical stenosis with myelopathy. He didn't have any actual neck pain before that. He had the surgery done. After surgery, he did well for 2 weeks. His myelopathy improved, but then suddenly everything got way worse and deteriorated. When I saw him, he really had pronounced ataxia. He could barely walk without without a cane, and he also had significant neck pain. He was pretty obese, or he is pretty obese, and he has really a huge neck. I'm going to show a CT scan afterwards. I think he weighed 450 pounds, if I'm right. And his neck looked like he was weighing 600 pounds. So it was impressive to me that that surgeon was able to do that ACF in the first place. Other than the diabetes, he's pretty healthy. That's the actual x-rays that I got when I first saw him. Shows the ACDF 3.4.5. Nothing too obviously wrong on those x-rays. At that point, he was just 6 months out of surgery. Now on the left side is the MRI the patient had before the surgery. And that shows that at 3.4, he has quite some pronounced quad signal changes. And then on the right side, the MRI that he had just before I saw him, that was when he was really deteriorating and his myelopathy was really progressing. It does show, obviously, that the quad changes are still unchanged. The sagittal view shows, I think the sagittal shows that there is probably CSF flowing posterior to the quad, but the axial section actually shows that it's still somewhat tight. Now, the next step was for me to get a CT scan, and that CT scan at 3.4 really showed that there were bilateral, quite some osteophytes left. And it was not a surprise, because if you take a look at that axial scan, as I said, he had a huge neck. It was pretty high up in the cervical spine. So those osteophytes were just below the disc level. So it made sense to me that the surgeons, probably because of his neck, couldn't quite get the angle to take these osteophytes down. Yeah, so that's how the CT scan looked like. Now, I guess at that point, the question becomes, are we sure that these osteophytes really causes symptoms in terms of myelopathy, in terms of neck pain? Do we feel comfortable to do another surgery? If we decide to revise that, how would we do it? Would we go in through the front again, or would we do some type of posterior surgery? Thoughts, please.
Wow. And the BMI, and the patient has got diabetes. I remember one case with the same findings, like myelopathy signal hyperintensity in T2 posteriorly, and everybody thought, yes, it's myelopathy, and the patient was a diabetic, and we did surgery, and there was no, he was not getting better. And 1 month later, the neurologist found a rapid progression of a peripheral polyneuropathy. So it was the diabetes and the neuropathy that was the real problem. Do you trust your neurologists with these SSVP and the neuropathic? Do you repeat all the measurements 1 month before surgery, or What's your workflow?
So, I do trust my neurologists. I mean, it's not my neurologists, but I do trust our neurologists. And whenever there's any doubt that the patient might have something else, obviously I send them to them. And they're pretty straightforward in telling me, okay, this guy needs surgery or this guy does not need surgery. And this guy actually, even though he came from out of state, I introduced to our neurologists, and they basically agreed that there's nothing else going on other than probably an unresolved mechanical problem.
Yeah. And do you think that the fusion is already there after 6 months?
So when I first saw him, I thought that his neck pain might be an indication that he might be loosening his hardware. I think based on a CT scan, that looks, I would say, appropriate for being 6 months out of surgery. Obviously, there is not a dense fusion yet, but I think it's going in the right direction. I don't think there is any loosening. So I don't think there is, based on that, I don't think there's a strong necessity to revise that fusion just from a mechanical perspective. And I think that leaves us with the question, you know, should we again go in a neck that is huge, that is difficult to expose, that has scar tissue from the previous surgery, or should we go in through the back to do whatever could be done? So I think that's another question that needs to be answered.
Yeah, there was a question from the chat box. Any chronic ischemic disease from the cord could be a differential, but the neurologists say it's a myelopathy. It's a compression, ongoing compression.
So the neurologists, I mean, they're pretty smart, the ones that I'm working with, and they just frankly said, okay, that's just mechanical. So in this case, even though, I mean, I would not be capable of telling all the differentials, but in this case, apparently the neurologists felt it was just mechanical.
Yeah. So in my hands, I would just decompress, look whether it's a highly mobile or it's fused. Actually, in neck pain, with this situation, I think I cannot tell you whether I would extend a fusion to C2, 3. Maybe there are some facet osteoarthritis as well in the X-flex X-ray visible, but I cannot tell you where the neck pain comes from with this obesity in this setting. I think you said it's a bread and butter case, but I think this is a dilemma case as well. I would go to the necessary procedure and I would just decompress, wide decompression.
But would you come, so basically you would go through the back, is that what you're saying?
Yeah, I would not dare to go from the front.
So if you look at the axial CT scan, as you can see, the way down to the spine through the back is also pretty long. So anyway, so any other thoughts by anybody else in the audience?
Yeah, I would love to hear some from the experience and from the fellows and the residents, some thoughts going the long way from posterior. We all know that the neck pain post-op is a lot worse when you go from posterior, but you can achieve a better decompression from posterior. I think this is a perfect case to see the limitation of ACDF surgery in an obese patient if you go more and more high cervical. There is from Dr. Awe the recommendation going for C4 corpectomy. Of course, we know it's not a good surgical candidate. Dr. Bertschel, you're absolutely right. But in the end, if there is a myelopathy, we know from many studies that a proper decompression can heal the patient, and the quality of life can be a lot better.
Right. So I would agree. I think you're in a position where you have to do something because the guy he can barely walk anymore. And in fact, I think I scheduled him already, and then he came to our ED a week earlier because his left upper extremity was getting more and more weak. So I think there was quite a need to do something. Now, with this ventral ventrally based compressive lesions, I felt it was necessary to go in through the front. So I went in through the front again and did what somebody in the chat apparently suggested. I took out everything. I did a corpectomy. I totally skeletonized the C4 roots on both sides. And to my great surprise, after surgery, the neck pain was immediately gone. So I think that tells me that, in fact, he had probably a C4 radiculopathy. His swallowing was not too bad. And that was, I think, only because I did a contralateral exposure. His initial exposure was from the left. I went in through the right. So his swallowing was not too bad. And then he called me up, I think, 2 weeks after surgery already, and told me that he was walking without a cane. He was improving. So it was quite a success story so far. And I think the key to this case was really to basically treat the offending cause, which is a ventral osteophyte through the front. And obviously in a revision setting, I think it's really important to come from the contralateral side, really, to avoid any pronounced dysphagia. And it went well in this case, but it was quite a struggle to expose that neck. I will not lie to you.
I believe this is obesity, short neck or no neck, we call it here, is a really challenge. May I come back to the etiology of the neck pain? You mentioned that it is could have been a bilateral C4 radiculopathy. So I think we all know that C4 radiculopathy can be really a challenge for us to hear, to listen to the patient, and the distribution, because the arms are not involved at all. It is somewhere in the muscle. The patients have got a long history of physio and massage and everything. Do you have any key in the history of the patient, any key expression the patient gives you that you say this is C4?
No, absolutely not, because I still remember that day I was with a, no, it was not the day, it was the day before, with a resident seeing patients, and I still remember told him that the C4 is something that I doubt even exists. And then that patient really complained so much about the neck pain, and right after surgery it was gone. And looking at that CT scan, I think there is no other reasonable explanation other than a C4 radiculopathy. So I think, at least in my experience, probably that's something that I myself do underdiagnose significantly.
Yeah, this is brilliant, because this is a nice case, really nice. This unspecific axial neck pain in an obese patient, maybe it is, but maybe it's a specific radiculopathic pain due to these osteophytes. I love this case very much. But still, I would go from posterior and try to do some foraminal perceptotomy, burr a little bit.
I think if you go posterior, so that patient the day after surgery said he had no more neck pain. I think if you do posterior surgery on him, he might call you 3 months after surgery and still complain about his neck pain. So
you're right. You're right. I learned something today.
Right. So
thank you.
Let me come to the third case. So that is actually, at least in my experience, probably one of the toughest cases in terms of decision making. So I'm curious on what the thoughts of the audience are on this case. So it's a 75-year-old patient with a long history of multiple sclerosis. She's been in a wheelchair for 20 years. She's paraplegic. She's quite contracted in her lower extremity. She has quite pronounced hip contractions. She's also numb from the belly button downwards. And really her issue was, over the last a year or so, that it was increasingly difficult for her to sit in the wheelchair. She noticed that she was always tilting to one side, and also she noticed that she was leaning forwards and almost falling over in a sitting position. And then at some point, her husband noticed that a hole opened up in her back. And I did not mention yet that she had a prior fusion surgery L1 to S1, which was done 16 years ago. And so I see her, she looks really in a horrible shape. She can barely sit. And really, she does have a skin breakdown and exposed spinal hardware. So this is how her sitting whole spine X-ray looks like. She had these Steffi plates put in 16 years ago, and right where one of the plates really is closest to the skin is where she leans against her wheelchair, and that's probably where that plate eroded through the skin. And because of her paraplegia, she couldn't feel any of this. Now the coronal X-ray also shows her coronal imbalance and her difficulty really to sit straight. Now that's a CT scan that basically shows her previous surgery, L1 to S1. It's fused except for the 5-1 segment. She has quite a thick fusion mass here at the junctional area, at the thoracolumbar junction. And she then loosens her screws at L1 and S1. Well, so I think the question becomes exposed hardware. So per definition, an infection, what do you do? Should you do any surgery or should you maybe just have plastic, somehow close that? Should you just remove the hardware and then have plastics close it? Or should you go all in and open up everything, correct the deformity, have plastics, reconstruct the defect? And if you do so, what are your alignment goals in this patient?
Alex, may I ask you, what is the pain for the patient? Did she
have no
suffer?
pain. No. She has no pain because she doesn't feel anything from her belly button downwards. So really the issue is skin breakdown plus inability to sit, which obviously is a huge issue for her.
Yeah. May I ask you, you have your own career. When did you first see a Steffi plate? Because Steffi plates are absolutely rare here in Europe. I have never seen a Steffi plate here. The only patient was a Canadian patient coming to Switzerland and living here with a Steffi plate. And we were looking here and the plate was in the bone. Dr. Birchuk mentioned that Steffi plates are hard to remove. There are many Twitter tweets about Steffi plates as well. What did you think when you first saw a Steffi plate coming from Europe?
So to be honest, this case is the second Steffi plate that I saw. And I don't want to take away too much, but obviously I did surgery for this patient. And I was warned by everybody that it's a nightmare to remove. It was in this patient, actually, it was not too difficult to remove, at least on my side. On the other side, on the fellow's side, it was a bit more challenging. But in the end, with the right instruments, it came out not too difficult. But I heard that it can be notoriously difficult to remove here.
Yeah, we have other difficult implants. Dr. Barbali from Florence mentioned that he hasn't seen in Italy any Steffi plate at all. So when I would have to treat the patient, I would go to the second. I would do a hardware removal and look for a good bone closure with the plastic surgeons. This would be my to go, because she is paraplegic and the bone looks so badly, so weak, so osteopenic. When I want to try to correct any coronal deformity, which is harder than to correct the kyphosis, but this is both, it's a kyphotic and coronal imbalance. I would choose the easier way and go for what is necessary, and this is the hardware removal and skin closure.
I think that is very reasonable. I think the only issue I had with that conceptually is that she had this long laminectomy right there, and she is not fused at all at 5-1. So my fear was, and the patient pointed that out several times, that really it's very important for her to be able to sit. And my concern really was if you take out everything, that she would collapse here at 5-1 and not be able to sit anymore, particularly in her because she has no muscle tone in her trunk muscles. So I think that was my main concern with just removing everything.
Okay.
All right. So yeah, any other thoughts?
At the moment, we are really looking forward to see your solution.
Okay, so obviously did surgery. It turned out to be difficult from the beginning to the end. So positioning was already quite a nightmare because of her contracted hip and knee joints. That shows again her skin breakdown, but it also shows something that I was not fully aware when I first saw her in the office, that she had quite an extensive area of the cubitus. And later in the case, it turned out that that whole area here showed extensive subcutaneous necrosis. So I think if I knew that before, I might have changed my plan. So she didn't have any significant medical comorbidities. So I thought, so I did decide to basically go all in and correct the deformity, allow her to sit straight, and also obviously with plastic surgery to close the defect. And so that's what we did. Basically, we did a T4 to pelvis fusion, removed the Steffi plates. She had a kyphosis just above that at the thoracolumbar junction, and there was a thick posterolateral fusion mass. And we also cut the fusion mass at T12, L1, L2, also cut the fusion mass at the lumbosacral junction, and then instrumented her from T4 down. She did surprisingly well. I should say for the first 3 days, she didn't do so well. She was in the ICU. She was intubated for 2 days. Plastic surgery took him actually 5 hours to reconstruct everything. But after that, she's been doing fine. The paraplegia definitely worked for her in the sense that she barely had any post-op pain. And I think after a week after the surgery, she was able to sit. She felt sitting was way easier for her. She could sit up straight. So in that terms, it was a success. I mean, obviously the potential downside is her bone quality. And I think it remains to be seen if she really fuses or if anything bad is going to happen. But for now, she's doing fine, fortunately.
So this is an interesting case. No matter what the spine surgeon does, the plastic surgeon leaves some extra times. We mean
that is true.
Yeah, we know from tumor surgery in the sacral region that sometimes the chordoma is out in 60 minutes, and then the plastic surgeon comes and they need 4 or 5 hours. Right. May I ask you, when I look at the skin, and Dr. Birchett mentions in the chat box, what about the cultures? It must be a super infected situs.
Oh yeah.
Did you put her on antibiotics for 3 months, or what was your management from the infectious disease?
All right. So in fact, we removed the plates and we took a bunch of samples, and she was shown to be positive for E. coli, for Candida, in fact, and for some other bugs. So she's on a triple regimen, and it seems like ID wants to keep her on an indefinite suppression therapy. So it was heavily infected, even though there was no frank pus anywhere. It was just a little mushy tissue, so it didn't look horrible, but it was obviously from an ID standpoint a bad infection. It still is.
Yeah, they're a lot more anxious than we are. Huh?
Oh, yeah.
So this is really a nice case, and the good thing is that many paraplegic patients have no pain at all, and they tolerate major surgery from this point incredibly good. where sometimes when we do microdiscectomy, the patient is post-op with a back pain 10 of 10, and really awesome result. Thank you very much for this case, Alex.
Well, sure. So I think it's 45. I think probably time for one more case. It's actually my last case. There is a 73-year-old man that had COVID. I think he caught COVID probably in the second wave. That was roughly a year before I saw him. And since he had that COVID infection, he had chronic cough. He also had a prior cervical spine surgery. He had a C5 and C6 corpectomy done in 2015. And actually, since that surgery, he has been having some mild dysphagia and some mild chronic cough. So when he got that COVID infection, since then, he's been really constantly coughing for a year or so. It was then until maybe 3 months before I saw him that he developed some chronic and increasing neck pain. And also when I saw him for the first time, really his neck was dropped in the sense of a dropped neck deformity. And I asked him, what about his neck posture? And he told me that he didn't really notice it so much because his neck was gradually just dropping forward, and it was clinically very stiff, so he couldn't really extend the neck at all, and it was painful. He was a pretty healthy guy. He had no significant comorbidities. So that the CT scan that actually looks quite suspicious. He had that corpectomy done, as I said, 6 years before that CT scan was done, and still the scan shows a lot of air, which is obviously very concerning. It also shows that there's some bony destruction just below. It also shows that there's quite some instability with what appears to be a retrolisthesis of 7. And the whole spine standing film shows the kyphotic deformity, and it shows also the way he compensates for that deformity by increasing or trying to increase his lumbar lordosis and flattening out his thoracic spine. He didn't have any neurologic issues. He was walking normally, normal fine motor skills, normal reflexes. And the MRI actually shows that at the lower junction of that fusion, it's 7T1, he has an impending cord compression. He did have quite some fluid or inflammatory tissue ventral to that plate, and it looked quite concerning, the whole situation. Well, so I guess at that point, several questions we need to ask ourselves. Obviously, there is an infection going on. Should we maybe just treat the infection at this point after we get a biopsy and able to do some targeted antibiotic therapy? Do we have to do any surgery? As I said, he's neuro intact. If we do surgery, what do we need to do? Do we need to remove the hardware? Do we need to stabilize the spine? Is there any role of preoperative traction? So that's just a few questions for the audience.
Yeah, so while the audience can write down their plan into the chat box, I wonder, did somebody look into the esophagus? Was the esophagus intact, or were there any? Sometimes the gastroenterologist sees the implant before the surgeon sees the implant.
So they did a swallowing study, and there was no esophageal leakage or perforation, whatever, visible on the swallowing study.
Okay, and my first question was how many years? It was 2015. It was like 7 years.
It was 6 years after his initial surgery.
But there have to be some follow-up studies in between showing some problems, or was it patient without any pain or any deformity in between?
Yeah, so he was apparently, up until 3 months before I saw him, he was according to him, he was doing fine, and he definitely had no neck pain, and he had a more normal neck posture. But I don't have any follow-up studies on how he looked a few months earlier.
Yeah. So this is so important for us because when it's a late onset infection, or whether it's an ongoing chronic infection, can be different in your treatment plan. But I think here we see the majority in the checkbox is going for anterior revision surgery and posterior then. 360 is recommended by everybody, anterior posterior. And I think it is, from my point of view, it's mandatory to take out the hardware, to make biopsies. And in the same setting, in the same surgery, you need some anterior construct, some anterior reconstruction, and then flip the patient and go along from posterior. I guess here we need decompression, C2-3 as well, and below C7, T1. So I would do a long construct from C2 to T4.
I think that's all good thoughts. I would say, from my perspective, one huge concern that I had was that he did the swallowing study before surgery, and it was found that his swallowing was just barely functional. So my concern was just going in through the front might really tip him over the edge, and he might not be able to properly swallow. So there was a concern. And the other concern was really his neck, his deformity seemed, from a clinical perspective, very stiff. So he could not move his neck at all. And if you look at a CT scan, if you look at the where the actual infection is, which is just below the plate, that is just barely at the level of the manubrium. It's very kyphotic. So I think I had quite some concerns getting a good exposure through the front, and also regarding his swallowing. So I talked to our ID docs, and I told them about the concerns, and they said, actually, what we can also do is we can try to leave the hardware in and just leave him on antibiotics at least for a year and see what happens. And that sounded appealing to me, and definitely to the patient, because I mean, who wants a feeding tube? So which is why I decided to basically just correct the deformity, stabilize the spine, and then hopefully have the antibiotics do their part. So he had a biopsy of, I think, T1. He had 2 weeks of targeted antibiotic therapy. And then we took him to surgery, and we did a T1 PSO. We also tried to debride as much as we could of that osteomyelitic area at C7, T1. And then we fused him down from C2 to T4, and didn't do anything through the front because of these concerns that I just talked about. And he's been on antibiotics since then. Now, post-op, it was not a very, I mean, obviously it was rigid, that kyphosis, but it was not like a solidly fused rigid deformity. So after really debriding that area, the deformity got quite flexible, and we were able to really bring his head up and lock it into a pretty neutral position. Then he's been on antibiotics after that, and then he got a follow-up MRI, I think 3 months out of that. And it's quite surprising. His labs returned to almost normal. All his ventral compression from debridement plus the antibiotics disappeared. His swallowing is, at least it didn't deteriorate. He didn't need a feeding tube. So from that perspective, it was a success. Now, the downside obviously is he probably needs at least a year of antibiotics, maybe even longer than that. It was also a substantial surgery, 2 liters of blood loss. He was on vancomycin at that point already for 2 weeks. So he developed some acute kidney injury after that. And from the PSO, he has some C8 dysesthesia on both sides, but at least he does not have any motor deficits. And he's doing quite okay at this point. So I think it was quite a good teaching case for myself as well, because I think one should not underestimate the power of antibiotics. And I think having a good conversational discussion with infectious disease, I really think opens up a lot of different options one might not think up from a surgical perspective.
Well, thank you very much, Alex. So it is, I think this case highlights the importance of interdisciplinary approach, the ability to perform osteotomies, like T1 osteotomy. You mentioned an S1 osteotomy in the first case, which are really challenging. This is not common, and keeping the patients for a long time under antibiotics is in the elderly patient sometimes a very wise management. Also, the kidneys don't like it, as you mentioned. May I ask you, do you perform CAT scan to look what happens from the fusion mass anteriorly? When would you go from anterior in this patient? What must happen? What would be your plan to go from the front?
Well, in this particular patient, he's quite a particular guy. He gave the whole hospital staff a very hard time. And I think he would be very intolerant to any situation where he knew that he needed a feeding tube. So because of his poor feeding, I think I think any more interior work would probably tip him over and he would not be able to swallow. So I think I would be very reluctant to go in through the front end. And I had an open conversation with him and he was very understanding of that. And he said, you know, he would be okay just taking antibiotics for the rest of his life. So I think for now, the plan is to leave it as it is and really not touch the front.
Yeah. In case, this is a question to the audience, in case you have to go in a challenging situation to the spine from anterior, what colleague will you call? Would you call ETN or would you call a general surgeon for the approach? Would you call a vascular surgeon? I have my own experience in the last 20 years. I would know who I would call. But Alex, who would you call helping you for the approach, dissecting the spine and the esophagus? Which specialty would you call?
ENT.
ENT.
Yeah.
So I'm waiting for the chat box. Dr. Babali says ENT as well. Yes. So I would call not ENT. I would call my general surgeon who does the parathyroid surgeries, because the thyroid surgeon and the parathyroid surgeons, they are really deep in the neck and they can extend far down to the mediastinum to look for the parathyroid glands, and they are a lot more often near the spine and they are very skilled in treating the esophagus as well. So I would look for a thyroid and parathyroid surgeon. These are fantastic surgeons. And the other discipline I would like to mention is a thoracic surgeon. Thoracic surgeon can go through the thoracic aperture, to the upper aperture in minutes, and they're really skilled as well going through this approach. And ENT is available, yes, but they are very busy sometimes, and then they have like a time slot for 2 hours or 3 hours, and then they disappear in their private practice. Alex, thank you very much. Dr. Spiessberger said thank you very much. Impressive cases and really smart solutions. Not always the standards, as you mentioned, but really impressive solutions. And I learned a lot. I will go for a C4 radiculopathy from anterior and not from posterior. And next week, Dr. Basch will show his own cases. And I say thank you again, Dr. Spiessberger, for presenting your cases. And I'm looking forward to see you again here on this conference. And I say goodbye to everybody. Stay safe, and we will see you next week.
Thanks for having me. Good night, everybody.